All right, part 2. We are going to continue from the current slide. Come on now. All right, the current slide. Nursing care of the family. This is chapter 21. You know, family-centered care, you can't say it enough, is really important in OB. A lot of the hospitals have been developing family-centered care for their med-surg areas, trying to develop a hospital that centers on the family, because family is very important in helping a family member maintain compliance with their medications, their treatments, and helps them stay knowledgeable about what's going on with their family member. I think they stole this idea from OB, because OB has been family-centered care from the time that I have been doing family-centered care. I don't think a lot of other nurses realize how family-centered the obstetrical nurses have to be. But they definitely understand what family-centered care is. You have to be able to bring in the father, the grandparents, anyone who needs teaching in that family, the siblings. Everybody needs to know how to take care of mom and the baby once they come home. Siblings need to be taught certain things about what they should and shouldn't do. Dads need to be taught nearly everything that mom needs to be taught, so that he can be more helpful in helping her reach her goals of becoming back to her pre-pregnancy state. So, we are going to educate. So, obstetrical nurses tend to do more nursing education, I think, than any of the other nurses on the floor. They educate toward the disease process. We're going to we teach toward a life process. So even though we are considered a normal, this is not a disease process, this is a wellness oriented thing. There is tons and tons of teaching in order to maintain the wellness. This is why you see obstetrics, postpartum things are usually noted in the NCLEX in health maintenance, because we want to maintain the health of the family. And so all of these things are things we address. We're going to, first of all, assist mom with her recovery. We're going to teach her about rest. And we want dad to know about these things. These are things we're looking for with mother in recovery. How she needs to rest, how she's going to adapt after birth, how we're going to assess for that, how we're going to prevent complications, and all the needs of the family. There may be specific needs of the family that we need to address. So actually, the postpartum period is actually, again, like I stated earlier, is considered the fourth trimester, and it usually lasts 3 months after delivery. So the fourth trimester is a pretty long trimester. So you have your first, second, third trimester, and this is your fourth trimester that follows your fourth stage of recovery. So we actually have to consider this as part of the pregnancy and what we are trying to learn about it. Then we have transfer from the recovery area. This all depends on your hospital setting. A lot of your hospitals have LDRP rooms, which are when the mom comes in and she's in labor, and if we don't know she's in labor, she goes in the triage room. Then we determine she's in labor, or we knew she was in labor when she walked in the door, she goes into a labor and delivery room. These labor and delivery rooms are now, once they deliver, they stay in there for their recovery, and they stay in there for their postpartum period. And we actually have the room set up where the baby stays in there as well. And so LDRP rooms are what you're actually going to usually see instead of receiving a transfer from a recovery area. Now, a lot of the larger hospitals still do not do the LDRP rooms, and I've been doing LDRP room or family couplet care for at least 15 years. out of my 25, 30 years of working in OB. When I first started, you labored in a labor room, and then when you got ready for delivery, you transferred the patient into a delivery room, and then the delivery occurred in the delivery room, and then that patient was, the baby was transferred to the nursery, and the mom was transferred to a uh, room that would be her room, and she was recovered in that room as well as stayed in her postpartum period there. A lot of times the RN did the recovery, and then the patient was turned over to a postpartum nurse, which a lot of times was an LPN. So you actually did have a transfer from that recovery period or area to a different nurse. So you have to have, and some hospitals actually have a whole separate postpartum floor, whole different area from their labor and delivery that they actually transfer to another floor or another area of the hospital rather than being labor and delivery. So you really need to be aware that when you're doing this transfer, that you have to, not only does your patient have to meet certain criteria to be able to transfer them to the postpartum floor or to a postpartum nurse, you also have to be very careful of it and make sure that you give all the information that these postpartum nurses are going to need and nursery nurses are going to need. We're going to talk nursery when we talk about the babies at the next lecture. But we're going to need all this information in order to give the best possible care that we can give to our postpartum patient. So the nursery nurse needs to know some of the things that she needs to know. She needs to know all about the prenatal care. She needs to know how did labor progress. She needs to know what happened in delivery, what the infant APGAR scores were, and etc. So then the reason it's important is you can't give the best of your care if you're not aware of certain things. If your patient, for example, had an operative birth in the vaginal delivery, say she had forceps delivery, and this was not passed along to the postpartum nurse, she wouldn't know that if the patient started complaining about a lot of pain in her vagina, that it wasn't just because of the labor process. She would know that if forceps were used, there's a high likelihood that a hematoma could be forming on the inside of the vaginal wall, and that needs to be addressed immediately. The doctor will need to be notified, and uh, bleeding can occur that she's not seeing because it's forming that hematoma. So those are things she needs to know. Was the progress of the labor really fast? She'll need to know that, in case there's any tears that she needs to be monitoring in the vaginal area. So it's just so important. Large baby, is she going to have Anthony? Because if the postpartum nurse isn't taking the baby and the baby's going to the nursery, she needs to know mom had a 10-pound baby. There's possibility of postpartum hemorrhage. So mom's is not rubella immune. She needs to know that because she's going to have to give rubella information. Mom's A negative. She needs to know that so she can find out what the baby's blood type is to see if RhoGAM is necessary. So all this information is really important. And we hopped all the way over from when you're transferring over to planning for discharge. So when we're planning for discharge, we have to make sure that we start doing this at admission, right? Always, always. Postpartum nurses have to be prepared for mothers going home. But the criteria that has to be met before they can be transferred over, they have to be stable. I just want to go back to that because they have to be stable. In fact, I'm going to actually go back to that if I possibly can. Excuse me a minute. You always know to call when I'm Alright, I ended this. I don't want to end this. Let's just, we got, my husband has a terrible, terrible, terrible sense of timing when I get ready to do something. Alright, so planning for discharge. I already talked about how the postpartum nurses are going to have to prepare the mothers. And what I had wanted to go back and talk about was that the nurse, before you transfer them to the postpartum area, they have to be stable. Their lochia has to be rubria moderate. They have to have a firm fundus. The patient has to have stable vital signs. Everything has to be stabilized before they go into the postpartum period. And when you're transferring from a C-section, they have to meet certain criteria as well. And we'll talk about that at another time. And again, I apologize for the space of waiting in between, but I had to go get the keys to be able to get back in my office because I locked myself out of the office when I closed the door to try to answer the phone for my husband. All right, so once we have transferred them over to the postpartum floor, the postpartum nurse needs to start preparing them for discharge. She has 24 hours from the time of the delivery of the baby until they go home. And sometimes she doesn't even have that 24 hours. Every once in a while, she might be lucky if she has 48 hours. But most of your postpartum vag deliveries are going to go home within 24 hours of the birth of the baby unless there is some reason that they cannot go home. And that is usually based on GBS status of the mother because the baby might stay for an additional 24 hours. But mom could still be discharged at 24 hours. She'd just stay there with the baby. Or if the baby's not breastfeeding well, we could still discharge the mother and we could keep the baby in there. So the postpartum nurse has a big job ahead of her, especially when it's a first-time mom. And not only does she have to work around that short period of time, I say she's got 24 hours, and if mom's going to get at least 8 hours of sleep, hopefully in that period of time, in that 24 hours, that takes 16 hours away. So that leaves you with 8 hours to get in your postpartum teaching. Well, then she has to have her meals, of course, so that's probably 3 hours per day. So that's 6 hours. That leaves you 2 hours for doing discharge teaching. So then what are you going to do with all the family members that are, with all the visitors that are coming? Now, family members are in there. You need to be teaching them as well. But there is a whole lot going on in that particular room that you have to overcome in order to do your educational teaching. And it gets to be a really big challenge. A lot of the discharge teaching can actually be done in a prenatal class if the prenatal educator prepares them for what's going to happen after when they get ready to go home and what they need to be watching for, and actually have a postpartum class to help with breastfeeding and such. But those aren't always available. So we're going to start preparing them for discharge. We're going to be extremely challenged, and we're going to have to work for it and work with our patients, work with the family, work around the visitors, work around breastfeeding. All these things we're going to have to work around. So there's a lot of factors in themselves that's going to help that's going to influence our discharge. What's our physical condition of our mom and our newborn? If our mom is extremely fatigued from long labor, she's not going to be receptive to teaching right away. Mental and emotionally status of the mother. Is she mentally ready for this to go home? Is she mentally ready to assume the mother role? Is she emotionally ready? Did something happen? Is she anxious about going home and being alone with the baby? Does she have any support system at home? Will there be anyone at home with her? Especially if this is her first baby, she's going to be petrified to take home this itty bitty newborn. That she's heard all these horror stories, especially with SIDS being prominent in the news a lot. She's going to be horrified to go home without someone there that has a little experience with newborns. She's going to have a lot of educational needs, especially if she's a first-time mom. There may be some financial constraints that she has yet to address that she's going to have to address now. So these are all things that we have to consider when we're trying to plan for discharge teaching. We have laws that relate to early discharge and to discharge all by itself. We have a lot of things going on. So we have to be sure that we know our laws. And like I said before, most of your women are discharged at 24 hours. But there are some places that actually discharge at less. They still call 24 hours early discharge, although it's been the standard of care since I've been in nursing for the last 30 years, is that most of your vaginal deliveries go home at 24 hours. We are now seeing that there are some cesarean patients going home at 24 hours as well. If they're passing gas and they're doing fine and they want to go home and all we're doing is giving them a pain pill, then they don't need to be in the hospital. This, however, doesn't decrease their need for discharge. And C-sections, if they go home in 24 hours, will actually present a more of a challenge because the medication that they're on when they first deliver is going to cause them to not be able to understand what you're saying to them. I've actually had insurance companies call and say, when is so-and-so going home and why are you still keeping them, especially our C-sections. A lot of times we were sending some women home before they were ready. So we had to get some laws passed to ensure that patients actually stayed long enough to address problems. The insurance companies were putting pressure on us to hurry up and get them discharged home. If we had infants who had difficult feeding, they still didn't want to pay for all that. If mom was having problems postpartum wise or fatigue wise and she had 4 kids at home and we needed to keep her, they just didn't want to pay for all of that. So we had to have legislature step in and say, we're going to ensure our patients stay long enough to address any potential problems that our mothers or babies may acquire. So, Newborns and Mothers Health Protection Act of 1996. Now, this doesn't sound very soon to you guys, but this was a new law that came into effect while I was nursing in OB. So this came out, and we were so grateful for this because then we didn't have insurance people calling us at all hours of the night, day and night, wanting to know when we're going to send our patient home. They stopped doing that. So the law guarantees that new moms and babies, that even if they just had a vaginal birth, no complications, they can stay 48 hours if they so choose to. And the cesarean births can stay at least 96 hours after delivery. Be sure you guys know this. I didn't put this up here just because I thought it was interesting, although I do. The thing about them staying for 48 hours, sometimes your obstetrician doesn't want to come back up the next day and do another visit. He'd rather send them home in 24 hours because he feels like the only thing he's going to do is come back and discharge them the next day anyway. But he only gets paid a certain amount of money for that delivery, and so if he can send him home at 24 hours and he's not responsible for him for the next 24 hours, I mean, he is no longer on call at the hospital for that patient for that 24 hours. So obstetricians like to send them home in 24 hours. Patients have to stand up and say, I want to stay my 48 hours. Nurses need to stand up and say, patient needs to stay 48 hours. She doesn't understand postpartum care. She doesn't understand how to take care of herself. She is not able to take care of herself or her baby, and she needs to stay this extra 48 hours for more education and more care so that we can make sure that when she does go home, she's safe. So we have to stand up for them if they don't stand up for themselves. And then, of course, the cesarean births, like I said, a lot of them are going home in 48 hours. If they're passing gas and they're just taking pills, they feel like they're just as well off at home. Especially if they have kids at home, they want to go home and be home with their other kids, because even though they've got a new baby, they are definitely concerned about their other children. So the law is here and it protects these mothers, and it helps them be able to stay longer when they need to stay longer without fear that their insurance is not going to pay for it. So there should be certain criteria for this discharge. Um, there's different criteria for postpartum as there is for the babies. So certain criteria for discharge should be that, if they go home early discharge, if they're discharged like within 6 hours to before the 24 hours are up, being a vaginal delivery, and before 48 hours if they're a C-section, we should be doing follow-up within 72 hours discharge. So what does that mean? That means either the nurse, the pediatrician, the obstetrician should be following up with these patients. They should either be calling them on the phone, they should be going back into the physician's office. There should be some type of follow-up done within 72 hours if we're going to send them home in 72 and in early discharge. We have to be sure that we are determining the individual needs of the patient, and we hopefully will keep them in a sufficient length of time to identify any problems that they have. And if we identify any problems, we can't send those patients home. We can be held responsible legally if that mother and infant didn't meet the criteria for early discharge and we discharge them anyway. Say that part of our discharge, if the criteria for discharge is that they couldn't go home if they didn't, if they were still having moderate or heavy lochia, ruberolochia and we sent them home. That's not meeting our criteria. The criteria should be that they're stabilized. So we want to make sure that they're stable. So anything that would make you think that a mother's not stable, if she's emotionally not stable, if she's educationally not stable, anything that we feel like, anything that was not ready for discharge, if she wasn't ready to go home and take care of herself, if she was not showing she was able to take care of herself in the hospital setting, she definitely is not going to be able to do it at home. If she was not taking care of her bottom like she should, or taking care of herself like she should, these are things that we can get in trouble for if we discharge them early. Now, if the doctor comes in and discharges them early and we don't think they need to go home early, we need to be documenting that doctor came in, discharged patient, explained to doctor that patient was not, that nurse does not feel that patient ready for discharge, as patient's not demonstrating ability to care for self at home, focusing on her her perineum care needs or whatever. We need to be sure that we're documenting that. So This really means that we have to get in there and make sure that we are getting our teaching done and we are doing our documentation and make sure that we're documenting. If there was a problem, that problem better be documented, and it better be documentation on what we're trying to do about it in response to the patient themselves. You got your drug addicted moms that they want to get out of that hospital as soon as they can so they can go back to doing their doing their drugs. And we can't let that slip by that these patients may be drug addicted parents. If we've got, you know, if something's happened that we didn't get a drug screen on mom and therefore we didn't get one on baby, but then we realize later on, hey, this is a problem, then we need to follow up on that. So then we do physical assessments on make sure what our physical assessment is supposed to be. We've got a table in your book that's 21.1 on page 486 according to in your book that says what a postpartum assessment should be and any of your potential complications that could possibly be. So be sure that you read this. Even though we talk a lot about in OB about the fundus, the lochia, the perineum, the breast, we're always focusing on what's OB specific. We can't overlook the basics of assessment, of a physical assessment. We should still be, of course, assessing their blood pressure, their pulse, all their vital signs. We should be assessing breast sounds. It's very easy for them, especially if they've had a cesarean, to develop pneumonia. So we want to be sure we're doing breast sounds. And those are things, the abdomen, we want to make sure that we're making sure they have bowel sounds. We want to be sure and do checking their lower extremities, make sure they're not having a DVT, checking them for fatigue and their emotional status. So look at that table very carefully. There are some things on there that you really will want to know. Especially about the lochia. It tells you everything's pretty much summed up on that table. Lochia is on there like day 1 through 3. It should be rubra. Day 3 through 10, it should be serosa. And after 10 days, it should be alba. What it should look like, what should complications are going to mean. There's really a lot of information in there, and it almost sums up the whole chapter as far as the care you should be giving to your patient. We always do a routine lab postpartum day, especially H&H. We usually do a CBC on a C-section and an H&H on the vaginal babies and a vaginal birth. Basically, we do this to assess blood loss, and you have to compare. You can't just look at your H&H and say, oh my God, she's got a 26 hematocrit. If she came in and her pre-delivery H&H showed that she had a 28 hematocrit, she didn't have a very significant blood loss. However, if her pre-labor H&H showed that she had a 36 hematocrit, then a 26 is a significant blood loss. So always be sure to compare that first partum H&H to your pre-delivery to determine how much actual blood loss they have. It is not routine to give blood in the OB setting. These are young women who are expected to be able to replace their blood supply on their own and let the body naturally do that. If you give blood, it's usually only a 2 or 3 day reprieve because those blood cells are going to die and the body is not reproducing them as they would if they had a low blood count, and the body gets that negative feedback, says, hey, we need to make more red blood cells, we don't have enough, we don't have this, we don't have that, and starts the process. So you need to, so we don't routinely give blood, but we do give blood to symptomatic patients, and you may have a symptomatic patient with a lot less blood loss than you would have with someone who had a lot more blood loss. It all depends on the individual patient. Of course, with another thing that's you need to do if you have an Rh negative mother, they're going to draw a RhoGAM, draw for RhoGAM if the infant is positive. So you always need to know what the infant's blood type is on an Rh negative mom. If the baby is negative, they do not receive RhoGAM. If the baby is positive, then they won't get RhoGAM. Oh, wait a minute. I got off track. Wasn't thinking. If the Rh negative babies is positive, they have to get RhoGAM. If they have a negative baby, they do not get RhoGAM. We don't usually do a urine sample related to vaginal bleeding. If we suspect a urinary tract infection, she's had signs and symptoms of it, we will do a cath UA to do a urine after postpartum, after they deliver. Okay, so what are our nursing interventions going to be? Always individualize it. Always make sure we know what we're supposed to be assessing. We're usually out doing our focused assessment. And like I told you, that book, that little table in 21.1 is awesome for what we need to be looking for. What are some interventions that we need to be doing? And what for those nursing diagnoses. So we have a nursing care plan, postpartum care, in your book that has a lot of information on it as far as what you would be doing for your patient that is postpartum. I think it was, yep, it's on page 484. One of the very first things that I think you need to address immediately, and I'm so glad to see that the book finally has changed this and recognizes it, is that the risk for fluid volume deficit right after delivery in that fourth stage of recovery, you're watching that mother very closely for volemic shock. So you're actually looking for fluid volume deficit. That is your most important thing. They may be complaining of actual pain, but you let them bleed to death and you took care of their pain. You really didn't help them out a whole lot, did you? So you can have sleep pattern disturbance, especially if they're breastfeeding, alter patterns of urination if they've not got up and peed yet, caregiver strain if they're doing the breastfeeding. There's all kinds of things that you can actually come up with nursing diagnosis and what interventions that you should do for those. Now the uterine, the fluid volume deficit we've already talked about, to make sure that we're monitoring the lochia, make sure that we're palpating that fundus, make sure we're monitoring I&O, vital signs, be sure that we are checking their hematology, and how we should be handling that. So those are things we need to do. And remember, when you're doing your clinical reasoning tool, if you put monitor, you can delegate that to an LPN. If you put assess, then you need to be sure it's an RN. And as far as I'm concerned, if you're looking at something to see what it is, then you're assessing. So when I say monitor, it should be something that monitor the vital signs so that the RN can come by and assess them. But you need to be doing the assessing. So be sure that you use assessing instead of monitor for a lot of these things. You can express clots. You can administer oxytocin. You can teach mom how to massage her fundus. That's an RN thing, and there's your teaching tool. So all of that just is one nursing diagnosis. And like I said, to me, number one nursing diagnosis in the very first, if you are receiving a postpartum patient in your clinical and she has just delivered, this should be your number one diagnosis. I shouldn't see anything else other than this if she's just delivered. If you're taking care of her 12 hours, 24 hours, 12 hours later, and you're starting to plan for maybe her discharge, and maybe you're doing readiness for learning. So there's a lot of things that you can actually address. Or you're addressing a C-section, the first postpartum day, you've already stabilized her. You know she's not having any heavy bleeding, so she's not at risk for hypovolemic shock as much as she was. Then you're going to be probably going to acute pain. So be sure you're using your reasoning to be able to figure these out. And like I said, this care plan can pretty much do your clinical reasoning tool for you as far as if you're doing postpartum. So you really need to take a look at that when you're doing your clinical reasoning. So you probably should take your OB book to your clinical rotation when you're doing New Life Center. Okay. We always provide that direct physical care. We're going to be sure that we're going in there. We're going to be physically assessing the fundus. We're going to assess the breast. We're going to assess the legs. We're going to assess for DVTs. We're going to assess any type of physical things that she might need. Make sure she's going to the bathroom. Make sure her bottom's okay. Make sure her nutrition is okay. Any physical need that she has. Maslow's hierarchy of need. And then, of course, we've got to start teaching mother-baby care. We've got to teach mother how to take care of herself. We've got to teach mother how to take care of baby. This is where we want to have daddy in there. We want to make sure that we're teaching daddy how to do mama and baby care. We want to provide guidance and counseling. We want to be nurturing. We want to be mothering the mother. We want to be the person that's going to be her resource person. And we want to be highly encouraging, especially if she's breastfeeding, highly encouraging her to get up and walk. If it's C-section, everything we do, we should be encouraging them. Now, we do have a prevention of abduction of infants, and this usually, I would say, should belong in the baby portion of the lecture, but it has popped up in this lecture, so some of the things that a lot of hospitals have done to prevent abduction of children or of babies, of our neonates. Nurses have to wear special badges. The nurses at White River have pink on their badges, and no one else in the hospital has that pink stripe on their name. I'm not sure what Unity has on their badges as far as being able to recognize them by looking at their badges. However, they can't go into no one can get into Unity's nursery without a specific badge that will let them go into the nursery, and no other nurse on the floor can get into that without that specific badge. So most of their babies hang out in the nursery. Unless mom's requested to have them in there, they do have a dedicated nursery. So that is one of the ways they prevent abduction from the nursery, is that you can't get into the nursery. They also make sure that their wristbands are matching their mom's wristbands, but they also have an electronic bracelet put on, so that if once this electronic bracelet's put on, and both hospitals that we go to use what's known as the HUGS unit. Once it's placed, if it's removed without being disabled, alarms will go off and doors will lock down, and you won't be able to get out of the unit until that issue's been resolved. You'll either find the baby, find the bracelet. Sometimes those bracelets, if they're not put on tight enough, though, can be slipped off. And if they can be slipped off and left in the room, then and the baby's gone, then that's really not a good fail-safe. So when you're delivering a baby, you want to make sure, and even when you're doing postpartum or doing nursery, make sure that that bracelet will not slip over the ankle and fall off. I never ever want to see you guys carrying an infant in your arms to the rooms. You should always transport in a crib and instruct the parents to do so as well. White River is very strict on that. The only time the baby gets carried in the arms is if they're having a C-section delivery. The dad carries the baby from the C-section to the room, and then after that, that baby is transported via crib. Now, I have seen at Unity, several of the nurses have actually will carry the babies from the room to the nursery, and from the nursery back to the room without using the crib. You guys are not allowed to do that. If you are going to if the nursery nurse asks you to go get a baby, and you go get that baby, you transport them in the crib. This is a safety issue, and basically it is also a legal issue. If that baby gets dropped, and there has been documentation of babies that were dropped, that's why this particular safety alert has come up, is that you can be sued. If you drop a baby on a concrete floor, we think it's going to happen. Now, if mom's carrying it, you should tell her she should have it in the crib. It's not going to hurt for mom to push the crib around. If they want to go for a walk and take the baby with them, put them in the crib and let them walk around the unit. That's perfectly safe for them to do that as long as they're inside the unit. They don't need to take the baby. They should never take the baby out of the unit. So things that you want to be sure that you're watching for. So you want to be very careful with those things as far as babies go. All right. Let's talk about preventing infection. Now, I don't think preventing infection should come before preventing bleeding, but we've already talked about how to prevent the bleeding. Uterine atony, making sure the bladder's moved over, making sure we're looking if our fundus is firm, we should be looking for lacerations or hematomas, some type of other thing for that bleeding. So we're talking normal labor and delivery. It should be just uterine atony, possibly infection that might prevent it to do that. So for those are some things that we need to make sure to prevent excessive bleeding. There is a picture in your book that shows the lochia pads and what's scant and what's moderate. Be sure to look at those. It shows you all four of them. In fact, it shows you blood loss after birth and what is considered heavy, scant. And the question I might ask about that is, which one of those would you expect to see 1 hour after, or that you would expect to see 30 minutes after birth? Which one of those would you expect to see right before they go home? So you're going to need to know when these occur. When the heaviest bleeding is usually right after birth, right? So you would see the heavy pad. That one pad that they're showing you right there says that's a 2-hour pad. So that would be perfectly what you would expect to see right after birth. The other one that's moderate, you would expect to see that one with it, after the first so many hours. You would start seeing it kick down to that like within 12 hours. The scant one you're going to expect to see right before they go home. Now with a C-section, you might expect to see a scant one. I'll try not to be too mean and ugly about it. So those are some things I really want you to be sure that you're watching for. We've already said a pad that's saturated. Usually an hour saturation, we think that's anything less than an hour is what I've told you. Your book says in that little yellow box about 15 minutes or less. If it's 15 minutes or less, you're having such a bad hemorrhage, you better be acting on it right then. But if you've got one an hour or less, you're having hemorrhage that you need to be on top of. But if it's in 15 minutes or less, as your book says, you better be doing some fast action. If you're not calling the doctor and getting something, actually, you don't need to leave your patient. You need to have someone else call your doctor and get them to come in if they're not already there. So one thing we do have trouble with is accurate blood, being able to accurately assess how much blood. And the way we could actually be accurate about that is weigh pads before they're wet, weigh pads after when they take them off. And that way we will be able to actually accurately document how much blood loss is. The way it is now, we just do it visually. And if you are just starting out, you have a tendency to overestimate the amount of blood loss than underestimate. So you always want to be sure you're checking underneath mom's buttocks to be sure that you are not overlooking some blood. You can look at the pad, and the pad may look like there's only just a little bit on it, but when you roll mom over, there could be a pool of blood. I had a patient who her pad didn't have anything on it. We started to get her up to go to the bathroom. The whole back side of her pad was soaked in blood all the way up to the top of her bed through her sheets. Needless to say, we didn't get her up. She passed out in the bed. She got 2 units of blood. So be sure that you're always checking underneath there for blood. And of course, maintaining that uterine blood flow or uterine atony. To maintain uterine tone, you want to be sure that you're, checking it often, especially in those first few hours. Teaching mom how to actually massage itself. It's uncomfortable for us to do it, but if moms do it, it's a lot better for them to do it on their own. And what we're looking for when we're talking about excessive bleeding is, she says she feels weak, lightheaded. Y'all should know what the signs of hypovolemic shock. So you need to be sure and look at the emergency box on 487 if you don't know that. Okay? And of course, it shows you how to do fundal massage on page 488, and you need to use two hands. So be sure and look at that so that when we get into the clinic, you know how to actually put your hands. You don't just put one hand there. You've got one hand that's right between the mons pubis and the fundal part of the uterus, and then one hand to do the massage with up above. So be sure that you're looking at that. All right, now we're ready to go to infection. Want to make sure we have our environment's clean. We maintain dry linens. We make sure she changes her peri pad every time she goes to the bathroom. A lot of times they'll tell you, hey, I've only had this, I've been to the bathroom 3 times, but I've only got just this much blood on here, and I can't see changing my pad and wasting my pads. And it's not the point. The point is it has blood on it. It's a medium for bacterial growth. She needs to change her pad to prevent infection. It's not so much as the pad is changed because it's full. So they need to understand that particular mindset. Be sure we're teaching them how to do peri-care. We teach them to fill up a little peri bottle with warm water, and some hospitals use hydrogen peroxide. Some hospitals use a mix of betadine and warm water. Some doctors use only warm water. The most that I've seen has been hydrogen peroxide, about a fourth to a third away up in the bottle, and the rest with warm water. You will need to talk to your primary nurse or your instructor at the New Life Center to see what the actual solution is that they use to do peri-care. Be sure that you're instructing them to do this every time they go to the bathroom. It's always from front to back, and they always pat dry with their toilet tissue. This is one time when you're going to teach them to wash their hands before they go to the bathroom and after they go to the bathroom, or anytime they are handling their peri pads. If they change their peri pad in bed, they should wash their hands. And of course, we should always wash our hands and put on gloves. Herpes lesions. Staff can actually have herpes lesions. You come to work with a cold sore, or you can have a whitlow, which is actually a little herpes thing that's on your finger. It's kind of unique to healthcare professionals because they will develop that, and then it will be contagious to newborns. So anytime you have a cold sore or you have a whitlow on your finger, you shouldn't be working in the nursery or around the moms. They actually allow you to come to the hospital to work because they can't, for some reason, they don't follow that policy. You should be wearing a mask, because if you touch your cold sore, which is a herpes simplex, and unconsciously touch your cold sore, and a lot of people do that because cold sores are irritating and it's hard to keep your finger off of there, then you can spread that germ by simply touching their crib, by touching their bottles, by picking up their pacifier, or by actually touching them. So it's not, it's a real bad infection control issue. So you want to be sure that you are making sure that you don't go to, if you've got a cold sore, you need to call me and I'm going to put you somewhere else. I'm not going to let you go to the Life Center if you have that on your, uh, have a cold sore. If you're running a high fever, you need to call me so that I will usually take you out of the postpartum, or out of the newborn nurse. Actually, I don't let you in labor and delivery at all if you're having some kind of disease process such as upper respiratory infection, diarrhea. We don't want you around our moms and our babies if you're sick, because they'll get sick, and we don't want them to get sick. So I can put you in a different area, or you're going to just have to stay home. Of course, if they have lacerations, if they have perineal lacerations, we want to be sure we're doing that good peri-care to prevent the front to back, patting dry from front to back, washing the hands, putting on clean pads, and changing them often. So, Can't believe it. I guess just prevention. Excessive bleeding, of course. We're expecting that moderate amount. Let's see if there's anything on here I didn't cover earlier. We know that the most common cause of excessive bleeding is uterine atony. So the two most important preventions is that good uterine tone and preventing bladder distension, which we've talked about already. Whoops. We've also talked about retaining the placental fragment. So if they're still having bleeding beyond what they should have at the time it should be changing, we're going to suspect placental fragments. Usually when you see heavy bleeding, massaging the uterus is going to be your first action, and then you're going to make sure the bladder's not full. If you're trying to massage the uterus and the bladder's full, the uterus is not going to be able to stay contracted, so you've got to get that bladder empty. If they're having heavy bleeding and you can't get the uterus to clamp down because of that full bladder, you're going to have to do an in and out cath. It's not, or put them on a bedpan. It is not safe to get that patient up to the bathroom with that situation. We can also have those lacerations that we said you need to be monitoring for. We talked about those. Usually they're spurting. You can apply pressure if you see them, and that will help stop the bleeding. And of course, the doctor needs to be called. He may have to suture it. We talked about the hematoma being formed, especially if you have operative birth. And it's usually characterized by the mom having unrelenting pain in that perineum. And we're going to see those signs of hypovolemic shock because we're losing blood in the hematoma, even though we may not be seeing the vaginal bleeding. Okay, we done talked about that. We talked about that. We talked about that. We talked about looking at the paths. I've told you time and time again, blood pressure is not a reliable sign. You're going to be severely compromised and what you need to watch for. We've talked about all that. I won't have to talk about it again. All right, gently massage that fundus until it's firm. You should see a gush of blood. If it's been pulled in the uterus, there may be some clots come out. The correct way, I told you to look at the pictures in the book and how to do that. This is really very painful a lot of times if you have to dig in deep because, you know, the uterus is sore. It's been through a whole lot doing all that labor and stuff. C-sections have sutures in them. We don't want to massage the fundus of a C-section unless it is boggy. If we do fundal check and we determine that she has a firm fundus, especially if it's below at the umbilicals or below, and her bleeding is not heavy, then or her bleeding's within normal limit, we don't want to massage that fundus because it's very, very painful for a C-section who has sutures. And again, you can also teach the C-section mom, even just rubbing over the area will tend to stimulate the uterus to contract. We know how to prevent bladder distension by simply emptying out the bladder, right? So, if they are bleeding a lot and you find, if they're bleeding very heavily and their bladder is distended and you can't get their uterus to contract, you need to empty the bladder. We can prevent it from getting this bad by making sure they get up and pee or making sure we put them on a bedpan within a couple hours of delivery. We do not want that bladder to get distended. We want to prevent distension. So things that we know to watch for that will keep our moms from wanting to pee or needing to go pee: epidural anesthesia, pudendal blocks. These are two big issues with making sure that your patient pees. So once your epidural anesthesia wears off and your Foley comes out, a couple hours after that your Foley comes out, you need to get them up and go to the bathroom. Pudendals, couple hours after they deliver, they need to get up and go to the bathroom. If their legs aren't working, of course you don't want to get them up and go to the bathroom. Shame on you for taking out the Foley catheter before they had full function of moving their legs and raising their buttocks off the bed. You just made your work twice as hard. You'll have to offer a bedpan, or you may have to do in and out cath again. Sometimes episiotomies, the swelling, lacerations, any of those things are going to put her at risk for not being able to go to the bathroom. So as soon as we can possibly get them up to walk, they should go to the bathroom. Bedpan again, if it's a lot of lochia going on there. We can run water. We can use the peri bottle on the perineum, put their hand in warm water. We can actually put them on a sitz bath. Sometimes giving them an analgesic like Nubain will help them go to the bathroom, especially if it's been an epidural anesthesia. Nubain is really good to help relax the bladder down. But we really would like to use all our non-pharmacological issues or methods to be able to do that. Discomfort's a big thing in postpartum care, especially for pain. You have a box in your book that talks about how to take care of episiotomy, lacerations, and hemorrhoids, which is pretty much we've talked about. The ice packs right after delivery, doing the peri bottle during the care. Sitz baths are wonderful things for perineal pain. We have, most of your hospitals have disposable ones, and a lot of times the nurse just plain forgets about giving you a sitz bath. But sitz baths, especially the episiotomies or second or third degree tear, these are or fourth degree and up to fourth degree. These are really wonderful, and there's instructions on each one of the little bags to tell you how to do it. But the bag should be filled with a little bit warmer water than what the basin is filled with, because it's going to be hanging and flowing slowly by gravity and causing a little bit of a bubble of water to come up and massage the perineal area. If it's hemorrhoids you want, you turn it one way. If it's the episiotomy, you turn it the other way. So some of the things we can do, of course, with the non-pharmacological things are same as we do with labor and delivery. All those specific non-pharmacological discomforts. But most of the time, the discomfort is real and it's caused by something real, and it's hard to concentrate on ignoring the pain. So some simple things that we can do to keep the pain from getting worse or from becoming bad, especially with the perineum, is to make sure we put the ice on for the first 12 hours, especially right after. You can also, of course, do the sitz bath in the local anesthetic. Be sure they're not sitting in a Fowler's position. Lying on their sides is going to prevent swelling, which is going to cause a lot of problems with the bottom. So you want to be sure that you're doing all that. And of course, the hemorrhoids, a lot of the episiotomy things that we do, interventions we do for that are good for the hemorrhoids as well. Sore nipples is something we're going to look at. And again, like I told you, tea bags are wonderful. And can you do that at the hospital? Sure you can. There's little tea bags in there in your nutrition room, so you can make tea for the mom. Will go in there and make her a bag of tea, and then put the tea in the refrigerator, let it cool off, and then when it gets cooled off, bring it in there and put it on mom's sore nipples. It's really, of course, they do have the lanolin. Your certified nurse, your certified lactation counselor, which you have one. You have actually an IBLC at Unity. She uses lanolin, but the last class I went to doesn't recommend using anything that would cause the baby to have a distaste. If you have that lanolin feeling in your mouth, just stick some Vaseline in your mouth and see how you like how it feels. So things that we're looking at with the nipples, engorgement is something that we need to be looking at. So we don't want to be working with any of those things. We want to be sure and go back to what I talked to you about. Whether you've got breastfeeding moms, you want to express heat, warm showers, make sure the baby's latching on correctly. Non-lactating mothers should have the actual binder placed on them. And of course, we can give pharmacological interventions for any of these things. We can give their pain medications as ordered. Usually there's a variety of it. We have the anti-inflammatory, they'll order Tylenol, they'll order opioids. So according to their pain, where it's at, and what their severity of it is as to what type of medication we would give them. Their epifoam, if they're complaining about their perineum pain, we can give them an epifoam. But if it's their perineum, that's from inflammatory response, you should be giving them ibuprofen. That would work well on that. So contractions or afterbirth pains, letting them lie on their tummy, putting warm heat. Non-pharmacological things, pharmacological would be ibuprofen, works best on that particular type of pain. If they're having more severe pain, then you might be looking at opioids. But we prefer not to give opioids, especially to our moms who are breastfeeding, because especially if the baby stays in the room, you don't want a mom to get knocked out on hydrocodone. So you want to be sure that you're monitoring the location, the type, severity, and medicating accordingly. Be sure you're inspecting any of those areas of discomfort to make sure we're not having an infection or hematoma or abrasion, especially in that episiotomy area. Nipples, make sure there are no lacerations or bleeding going on there, because we need to have our lactation counselor come in and work with them if that's happening. So we've already talked about all this. I didn't realize I'm just so good. I can't believe how good I am. Non-pharmacological ice packs to the bottom. That's absolutely, you have one in your delivery pack usually, and you can put that on right after delivery. But be sure you clean their bottom before you stick it on there. Make sure you clean off all of that delivery stuff. Of course, lying prone is going to help with those afterbirth pains, just like I said, and then lying laterally will ease the perineal pain. We've talked about all that. If they do get in the tub, if there's not a sitz bath available and they want to get in the tub, like we do have the jacuzzi tubs, they're not supposed to use soap. We've talked about how to take care of nipple pain. Be sure that we assess that pain and give medication for the appropriate pain. If we give pain medication, if mom needs something for pain and she wants a narcotic and she's breastfeeding, try to give that pain medication after breastfeeding to minimize the effects of the narcotic. And if possible, try to give her an ibuprofen instead. It's going to work better on uterine cramping than what a hydrocodone opioid is. Tell her to sleep when the baby sleeps. This is a big thing with moms. They get very fatigued. They have all these visitors, and of course they have to be awake and alert, and they want to make sure that every single visitor comes in they talk to. My gosh, it's like they're holding court in there. And it's very demanding on mom, and she doesn't get any rest. And if the baby's asleep, she's certainly not sleeping, and she's talking to all these other people. So we want to make sure that, maybe we need to go down there and put a note on the door saying patient is resting, please see nurse station. We need to try to do something to encourage mom to rest, because fatigue is the number one cause of postpartum depression. I'm not talking about postpartum blues. Postpartum blues happens to everybody that delivers a baby. But postpartum depression goes beyond that, and it's bad. And usually fatigue is going to be your number one cause of it. Mom is just too tired to deal with the issues of having a new baby. She's too tired to deal with the issues of breastfeeding. She's too tired to even care about anything anymore, and her mind gets in a fog. And this is how that postpartum depression can act, one of the major causes of it. So the fatigue is caused by all those hospital routines and breastfeeding and other children to care for. All these things, mom doesn't get to rest. So in the hospital, if you possibly can, try to cluster your interventions. If you've got a 9 o'clock med and a 10 o'clock vital sign, do your med and your vital sign at the same time. If you've got a 6 o'clock vital sign to do and you've got a 7 o'clock med, Then do your vital signs at 7 o'clock. Let her sleep. Now, lab's going to come in and draw blood on first postpartum day. Your lab people will usually come in at around 5, 6 o'clock in the morning. You see that lab person come and grab your stethoscope and haul your butt in there, do their vital signs, see if they need anything for pain, and take care of any needs, take them to the bathroom, whatever needs they have, and let them get some more sleep until breakfast gets there. We've got to start working to help our patients recover by keeping them from getting too tired. We always want to make sure mama gets up and walks. We don't want her to develop a DVT, which is highly possible when you're having a vaginal delivery or cesarean delivery. Moms are susceptible because of that, of those clotting factors that increase during pregnancy. Always assist the mother to the bathroom at least twice after delivery before letting her do it on her own. Because the first time you get her up, you want to make sure that her blood pressure doesn't drop. You want to make sure that she doesn't get fainty. You want to make sure she's able to move her legs and be able to walk on her own. You're going to do her pericare and show her how to do it. The second time you get up, you're going to let her fix her own pericare and let her show you she knows how to do it. So you have made sure she's safe and you have taught her how to do her pericare, and then you can let her get up and go to the bathroom on her own after that. Be sure and tell the family not to get her up to the bathroom. They are not saving the nurse any time or effort by not calling the nurse to come and help her go to the bathroom. We are doing that for our assessment purposes and to make sure she's safe. So be sure that you're mindful of those women who have had those epidurals. They think they're able to stand up, but they may not be able to. So be sure that they not only can move their legs, but they can lift their buttocks up off the bed by using the pressure of their legs, by being able to put their knees up. You'll have a lot of women that can actually, their legs will go out from under them just because their epidural hasn't worn off. I like to wait until their epidural has worn off enough that they can move all their legs really well, and then take out the Foley catheter, and then have them lift their buttocks up before I take them to the bathroom. And if they haven't requested to go within 2 hours, I always take them to the bathroom or put them on the bedpan within 2 hours after taking that Foley out. Of course, the walking, we're going to prevent those deep vein thrombosis. Once we get them up walking, the C-section guys can get rid of those sequential stockings. Those sequential stockings usually make a post-delivery mom very hot, and it's very irritating. So they're really happy to get up and start walking. Walking's, of course, going to help their peristalsis come back. So they need to be ambulating. Usually you don't have any trouble with a vaginal delivery getting up and moving around once you allow them to get up and move around. But your C-section moms are not going to want to get up and move quite as much. So you really have to monitor how much ambulation that they're actually doing. We can teach them to do the exercises in the bed. They can do the flexion extension, those plantar dorsal flexion things that we talked about in physical assessment. Of course, they can do rotation. So it's very important, especially with the lower extremities, and moving their buttocks from side to side to prevent bed sores, especially C-sections. It's really restricted on what type of exercise you do the C-section, but you can do the dorsal flexion extension. And you can actually make sure that we're turning them from one side to another at least every couple hours. That's to prevent them from getting bed sores. It's also to prevent them from developing pneumonia and things that we don't want them to. We like to get them up as soon as possible regardless. So as soon as a C-section feels like they want to get rid of their Foley catheter and get up out of bed, we get them up. Usually it's 12 hours. Nutrition, we got to promote nutrition. Sometimes they don't want to eat, they'll be really hungry after vaginal delivery. Sometimes cesareans are really hungry because they've had to be NPO. But we want to make sure that we are encouraging proper nutrition. They need protein and they need vitamins to help them heal. Not only C-sections because they have incisions, but vaginal deliveries have tears and they have episiotomies, but all of their body needs to recover and go back to the normal pre-pregnancy state. So we want to be sure we're encouraging them to eat diets that are high in protein and take their prenatal vitamins, especially if they're going to continue breastfeeding. And this is all going to help them heal. Incorporate any of their cultural preferences. Anytime that they do have a cultural preference, such as they like hot chocolate, well, hey, that's a, drinking milk, getting them some protein in there. So, offer that to them if we possibly can. If they like to eat burritos, well, beans and corn tortillas make a full protein. That's, try to make sure we're incorporating culture. Chinese eat more vegetables than they do meat, so tofu is a good protein, so we might want to encourage them to if they don't like to eat a lot of meat, to be sure they have tofu in their vegetable dishes. Be sure we're giving them stool softeners. Colace is a very good stool softener. That's not giving them a laxative, just giving them a stool softener, especially if we're sending them home with iron. They should be having about 1,800 to 2,200 calories per day. If they're not lactating, and if they're breastfeeding, they should have around 2,700 calories per day. Breastfeeders kind of tend to say, oh, I'm breastfeeding so I can eat a whole lot more because I'm producing milk. Well, you can see that's only like 500 calories more, and that's not even a Big Mac. So they might have a piece of chocolate cake for dessert, and bam, they got that extra 500 calories. So you need to caution them that it's not a free-for-all if they don't want to put on a lot of excess weight. We've talked about voiding, to be sure that she voids at least within the 6 hours. The reason I'm telling you 2 hours is because from experience, I know that if I can get them up and void them, let them void within 2 hours, then I'm not going to overdistend that bladder, and it's not going to be hard for them to urinate. So if I can get them up within 2 hours after taking out that Foley, then I'm at least giving them a chance to be sure that everything's working okay. If they haven't voided in that 6 hours, they have to have a catheter placed and have their bladders emptied. You want to measure those first few voids. Make sure that they're peeing at least 150 per void. They're emptying out their bladder. Usually after the first couple of voidings, they'll be putting out around 500 because they're diuresing. We've talked about the BMs. They don't usually have them. We can promote breastfeeding by putting them directly to the breast right after they deliver. It's a very good practice to put the baby directly to breast as soon as the cord is cut, whether they actually nurse or if they just kind of suck around. It's still going to help mom's prolactin levels stay high. They're very alert and ready to nurse, and that's known as the first period of reactivity. Babies are, they're like, where am I? What's going on? I hear a voice that I recognize. Oh, look, there's a face to that voice. It's really the best time for bonding and breastfeeding. This is the time where I like for the visitors not to be in the room. I like to tell them, hey, right after delivery, we're having a golden hour that's just for mom and dad and the baby to become their little family unit. They need this time to get reacquainted because they don't really know that newborn. They knew the fetus, but they don't know the newborn. And most people don't want to breastfeed with other people in the room. So you want to be sure to provide the best possible environment for mom to breastfeed so that breastfeeding can be conducive and be successful. If mom's not breastfeeding, again, put that support bra. If they don't have a support bra, go get one of those 6 or 12-inch ace bandages and wrap them in that ace bandage so that you prevent lactation from occurring. And again, don't use heat or express milk. We've talked about that till ad nauseum. So if you're using cold packs, you should have them on 20 minutes and off for 45 minutes. That works for the perineum as well. We've talked about rubella. It should be given after birth and before discharge to those women who are not immune. Look at that titer, guys. A titer of 1 to 8 or immunoassay level of less than 0.8 are not immune and they need the vaccine. So if you saw those levels, you would know they need to have the vaccine. If you saw a titer of 1 to 9, then that means they are immune. But 1 to 8, they're not immune. We've talked about it being a live attenuated virus, virus. Don't give during pregnancy, of course. And you shouldn't be giving it if anybody in the family's on chemo and they're immunosuppressed and they can't get pregnant. I've got on here for at least 1 month after receiving the vaccine. The brochure that comes with your rubella says 3 months. So really they shouldn't get pregnant for 3 months after they receive the vaccine because the virus can affect the fetus. The same goes for your varicella vaccines and your tetanus. Now, tetanus can be given. The tetanus, diphtheria, and acellular pertussis, this is all one vaccine now. They can be given postpartumly, but they can also be given prenatally now. So if they come in and they need a pertussis vaccine, they can actually take that while they're pregnant because it's not a live vaccine. We've talked about RhoGAM. It has to be given within 72 hours of an Rh negative mother that gives birth to an Rh positive infant. Remember that a Rh negative mother that gives birth to an Rh negative baby does not need RhoGAM. Our normal dose of RhoGAM is 300 micrograms, but sometimes more is needed. That's why they usually do a blood test to determine how many fetal cells are in there to determine the exact dosage. Some women have had to have more than one shot because the body actually had too many fetal cells, and so that they actually needed to have more than one RhoGAM shot. I personally have never seen that, but have heard stories from women who've said they've had several RhoGAM shots after delivery because of their high titer. So, if the Rh negative mother receives both the RhoGAM and the rubella, they'll need to be retested within 3 months for the immunity to the rubella because RhoGAM suppresses the immune response. It's much better if they don't get the rubella. We have had several negative mothers come in, and every time they come in to deliver a baby, they always need rubella. And it's because we never connected the fact that they had RhoGAM and rubella given at the same time, and RhoGAM canceled out the rubella immunity. So be sure that if you are giving a RhoGAM shot, that you check the rubella status and educate your parent that she should refuse any rubella for the next 3 months. Okay, we also have psychosocial needs. And the psychosocial needs, we don't think too much about psychosocial needs unless the mother starts acting a little bit funky. And we really shouldn't wait that long. We should really be on top of things as far as psychosocial needs and what the patient needs. And there are a lot of them. Effect of the birth experience. They love to go back and relive that birth experience. And you always let them do that. They can tell it over and over again. They like for you to tell the experience as well. So we're going to go over that with the parents. Some of the things that we really need to be looking for as putting them at risk for psychosocial problems is, if they're unwilling or unable to discuss that birth experience. Maybe it was so horrific they can't talk about it. Be sure they're not referring to themselves as being ugly and useless, that they are actually in a very happy affect on their face. They shouldn't be sad. They shouldn't be, we were looking for a lack of support systems. Be sure that the partner, see how he's reacting to the baby. A negative reaction by the partner can cause a bad reaction to what the mother does. I had one mother actually give her baby up for adoption because her husband said, "That's not my baby, and if you don't give it away, I'm not coming home." And she actually did. So it's really kind of sad how women can actually do those crazy things. If they're not reacting with the baby, if they're not talking to the baby, holding the baby, looking at the baby, that's a big sign that we're not bonding correctly. If they get upset when the baby pukes on them, instead of saying, "Oh, well, that's just what babies do," that's something we need to be looking at. So we need to be looking at all those things. Um, Cultural diversity can actually affect how we see whether or not that we're having bonding going on, um, and how they react in that postpartum period. So we need to make sure that we are assessing them according to their cultural practices. You know, like some cultures will put the baby in a corner and not name the baby and not look at the baby because they're afraid that it will bring down the evil eye on the baby. So there's you want to be sure that you, before you say not bonding well, that you know the whole cultural uh, background of your patient. A lot of things that can put mom back to this psychosocial postpartum depression is if mom is a single mom, if she is a low social economic situation, if she has no support system, um, if it's babies are not the sex that they wanted, um, if it was a maybe a pregnancy that would resulted in rape or incest. All these things put the patient at risk factor for going into postpartum depression or psychosocial needs, counseling that they need. So be sure that we're watching for that. Most cultures, well, actually all cultures, have developed safe and satisfying methods for taking care of their newborns and their mothers. They want them to be safe. They want them to be well taken care of. So be sure that we are alluding to what they need. There's a box on page 497 that talks about examples of cultural beliefs. So you need to look at that. And I think I thought it was very interesting about some of the things that we read about. And if we know about that, you work in an OB, you really need to know about that so that you provide adequate care to your patient. Sexual needs, of course, we didn't really talk a whole lot about that, but um, most of your doctors will go in and tell them they can have sex as soon as bleeding stops. I go in and tell them when dad, especially when dad's there, no intercourse for at least 6 weeks, nothing in the vagina for at least 6 weeks. If you're not supposed to put a tampon in there, don't put a penis in there. Don't be doing things that are going to cause possible infections. So there is teaching for managing sexual activity in a box in um, your book on page 498 that you can look over. We've already talked about the water-soluble gel should be used for lubrication. Sometimes the baby being in the room going to affect it. But, it takes up to 6 weeks for that perineum to heal. And actually, it takes even longer. Remember, we said 3 months for it to actually heal. So, it's really pretty uncomfortable for the parent having sexual activity for the mom, depending on how her delivery was. So it depends on mom as to when she really wants to resume sexual activities. But we tell them that the minimum for them to should be at least when the bleeding stops and the perineum heals. We should also talk about contraceptives, about how they should be sure that they have some type of birth control in effect, or because they can get pregnant from the time that within the first 6 weeks before they have their checkup, they can actually get pregnant. So you want to be sure that we're looking at that. So our discharge teaching begins at admission. It's highly individualized. If you've got a Gravita 1, they got to learn everything. If you've got a Gravita 4, there's a lot of things they're not going to want you to talk to them about, but they may have questions about other things. So let's target what needs that mom says, I don't know how to give a baby a bath. Well, let's target that. I've given the baby like 6 baths. This is my first boy, and I need to know about circumcision care. Let's target that situation. Anything the mother express needs for, especially when if they're a Gravita 1, we're pretty well sure that they need the whole gamut. if they are a Gravida 4, we definitely want to target what they need. Look at their labs. Look at medications that are ordered. Anything that we need to complete with them. Make sure their vaccines are given. Make sure their PKU is done on the baby. Make sure that they have a car seat for the baby and they know how to use the car seat. Those are things that we have to look at. I don't know how I got the car seat in front of the sexual activity, but I did. All right. We talked about that. Ta-da. I've got page 504 on here, and that's probably why, because I didn't get this far with, didn't look that far, because that's not page 504, it is page 498. So we need to be sure that they know about getting contraceptives. Be sure, if we can possibly at all, get a home visit. They're awesome to be able to send the nurse out to the home to see how the home environment is, to see how the mother's coping at home, to see how the family's coping at home. These are just really awesome things. We also have telephone discharges where either the nurse or the unit secretary will call. And it's better if the nurse calls, because if there is a problem, the nurse can actually address it, and they call about how they're doing at home. Warm lines that are available for questions for postpartum breastfeeding. Those are really wonderful things to have for the patients to be able to call and ask questions day or night. You get up at 2 in the morning, baby's not wanting to breastfeed. You might want to call somebody to see if there's something you could possibly help them with. Support groups, highly recommend breastfeeding support groups, parenting support groups, any type of community service like the Alpha Pregnancy Center helps supply, it lets them earn, I don't remember, some kind of bucks that they can trade in for car seats, diapers, and things that they might need. So I think that community resources are wonderful. The WIC resource, where if even breastfeeding moms can benefit from that, because they'll help mom with protein and breast pumps and whatever, and support them in breastfeeding. So community services are just absolutely wonderful. I'm sure Miss Candler has drilled that into your head. Oh, and it's over. It's over. But it'll start again eventually. We got to do transitions to parenthood.